Hello everyone. Today's lecture will be about anemia of diminished erythropoiesis. Now, anemia of diminished erythropoiesis is divided into, according to the underlying cause, into anemias of inadequate dietary supply of nutrients like iron deficiency anemia, folic acid deficiency, and vitamin B12 deficiency anemia. The other subtype is bone marrow failure, like aplastic anemia or pure red cell aplasia. The third one is anemia of chronic inflammation, and the last one is myelophthisic anemia, which is due to bone marrow infiltration by tumors or other inflammatory cells, limiting the bone marrow ability to produce red blood cells and other lines of cells. As you know, the bone marrow is formed of progenitor cells in the myeloid line and in the erythroid line and in the megakaryocytic line. So we have erythroid stem cells that produce red blood cells, and we have the myeloid precursors, which gives rise to white blood cells, neutrophils, eosinophils, and basophils, all the granulocyte series, in addition to the megakaryocytes, which gives rise to the platelets. So in cases of anemia, it can be part of just diminished or decreased function of the erythroid precursors, affecting only the red blood cells, or it can be part of a pancytopenia affecting the at least two lines like the erythroid, the myeloid, and the megakaryocytic lines, resulting in decreased red blood cells in addition to decreased production of white blood cells and platelets. Here we will only or mainly concentrate on the anemias of decreased red blood cell production. So iron deficiency anemia is the most common nutritional deficiency in the world, and 80% of the body iron is present in the hemoglobin circulating in red blood cells. Now, 15 to 20% of the body's iron is stored as ferritin and as hemosiderin in organs like in the liver, in the bone marrow, in the spleen, and in the skeletal muscles. Now, serum ferritin levels, which is measured by a sample from the blood in the lab, it's a good measure of the iron stores. Other indices or other measures of iron are called the transferrin. Also, it can be measured in the blood, which is the carrier of iron in the blood. So, iron is either free or bound to transferrin. Transferrin saturation also is a measure of the amount of iron, serum iron level, and the total iron binding capacity. Now, 20% of heme iron, which is derived from animal sources like in the red meat, and 1 to 2% of the non-heme iron, which is present in vegetarian resources, are absorbable. So, as you can see, the animal sources of iron are higher absorbed by the body than from the iron of plant sources. The main absorption site for iron in the body is in the duodenum, which is the first part of the small bowel. Causes of iron deficiency are either chronic blood loss, as we mentioned in the lecture of blood loss anemia, or low intake and poor bioavailability of iron, increased demands of iron, and malabsorption. So when you face a patient with iron deficiency, you should look for the underlying cause of the deficiency in order to treat the underlying cause, because iron deficiency anemia, it's always a sign of an underlying disease. It's not a disease by itself. So chronic blood loss, it's the most important cause of iron deficiency in the Western world, and the underlying causes includes peptic ulcers like gastric ulcers or duodenal ulcers, colon cancer, hemorrhoids, menorrhagia. It's the blood loss during the menstrual cycle if it is excessive and heavy. meteorrhagia in between the cycles, and endometrial cancer also can result in vaginal bleeding, leading to chronic blood loss. So, any cause of a chronic blood loss will lead at the end to iron deficiency. Low intake or poor diet, this is an important cause in developing countries, like in the infants, in elderly patients, in teenagers, in the areas which are common in poverty, or known to have poverty. So the poor diet is always also an underlying cause of iron deficiency. The increased demand, like during pregnancy, the patient or the pregnant lady needs to take extra iron amounts because there is an extra demand for iron by the developing baby. And during infancy, the first year of life, also the baby needs more iron, so he is at risk for iron deficiency, especially that the milk always interferes with the absorption of iron, which is the main diet or source of food in infants. Malabsorption, there is a lot of malabsorptive syndromes like celiac disease, حساسية القمح, or after gastrectomy, because the gastric acidity is an important factor to make the iron ready for absorption by the small intestine. So always we have to look for the underlying cause, because if there is a malabsorption, the patient will not benefit from taking, for example, oral iron. He should or she should be given parenteral iron or intravascular injections of iron. So the underlying cause is very important to identify before treatment. Characteristics of iron deficiency anemia: it's a slow onset, insidious onset. Iron stores are depleted first in the bone marrow and in the liver and spleen, so ferritin levels will decrease in the serum. There will be also absent sustainable iron in bone marrow if we take a bone marrow biopsy, although it's an advanced or invasive procedure ومش دائما بنلجأ له إلا if we think that the anemia is not just an iron deficiency. Decrease in serum iron levels, also low transferrin saturation in the serum, and increase in the total iron binding capacity to the transferrin, because we have low iron, so very much of this iron will attach to the transferrin. The capacity to synthesize products or proteins that contain iron, like the hemoglobin and the myoglobin in the muscle, is diminished. Now, the clinical features are mostly iron deficiency anemia is mild and asymptomatic disease. However, it can present with the non-specific signs and symptoms of anemia, which is the weakness, the pallor, شحوب. Sometimes, especially in children, they can develop pica, which is they can consume non-food stuff that, like they ate dirt, they ate clay, بياكلوا رمل, for example. بصير في changes في fingernails, like thinning, flattening, and spooning. Impaired work, impaired cognition, and reduced immunocompetence. The anemia in on a peripheral blood smear will be microcytic and hypochromic. So first, when you do a CBC, the patient will have a low hemoglobin level. You go to the next step to see the indices, which we talked about in the first lecture, like the MCV, MCH, MCHC, RDW. The MCV will be decreased. So these are the cells on the peripheral blood. The red blood cells will look small. We call them microcytic, and they have reduced hemoglobin because hemoglobin is not produced well because of the iron deficiency. This will lead to hypochromic cells. يعني the amount of hemoglobin in the cell will be reduced, and the central pallor اللي بنشوفها في red blood cell بتكون increased, as you will see in the next picture. Poikilocytosis, also variation in the shapes of the sizes of red blood cells, poikilocytosis and isocytosis. Platelets will be elevated. Erythropoietin levels are also elevated because the reduced hemoglobin will stimulate the kidney to produce erythropoietin, but then this will not be reflected by a bone marrow response because there is no iron, so the marrow response will be blunted. If you measure the reticulocyte count, it will be low على عكس الهيموليتيك anemias. So these are the red blood cells. As you can see, they are smaller in size than a normal blood cell, and there is an increased central pallor. There is a peripheral small red rim remaining in the red blood cell. This is called the hypochromic red blood cell. If you do an iron stain in the bone marrow, there will be absent iron stores. The second anemia of decreased production is collectively known as megaloblastic anemia, and it involves both folate deficiency and vitamin B12 deficiency. Folate and vitamin B12, both of them are required for the DNA synthesis and the thymidine part of the DNA specifically. So it's different from iron deficiency, which is needed for the hemoglobin synthesis that is part of the cytoplasm here. The problem is in the DNA synthesis. وبالتالي the synthesis of the RNA and the cytoplasm, they proceed at normal rate, so the amount of cytoplasm will be increased. So these cells, the red blood cells in a patient with megaloblastic anemia will have nuclear cytoplasmic asynchrony, that the cells are large, abundant cytoplasm, but they are immature سواء بالإريثرويد precursors في البون marrow أو حتى في الريد blood cells في البريفرال blood. The hematopoiesis or the erythropoiesis process will be ineffective. That the cells will be produced in the bone marrow and they will die in the bone marrow because they have abnormal nuclear maturation. Those patients usually present not only with anemia but with pancytopenia because folate and vitamin B12 are important in the nuclear maturation, also for the megakaryocytes to produce platelets. So these patients will have thrombocytopenia, and also in the myeloid precursors, which will produce granulocytopenia. فthe number of white blood cells will be reduced, خاصة the granulocytes. Now, vitamin B12 is also essential for myelin synthesis in the nerves. So, vitamin B12 deficiency anemia, in addition to the anemia, the patients will have neurological manifestations. وهذا هو الفرق عن الfolate deficiency, in which they do not have neurological manifestations. Both of these types of anemia will have the same morphology on the blood film because the red blood cells will be large. We call them macrocytic. The MCV will be high, more than 100 or more than 110. Also, the blood film will contain neutrophils with abnormal number of nuclear segments. We call them hypersegmented neutrophils. They have 5 or more nuclear loops. And the bone marrow will be hypercellular. There will be an increased response to produce more cells in the bone marrow. However, these cells will die in the bone marrow. That is called ineffective erythropoiesis. It is an erythropoiesis process, but there will be no increase in the red blood cells in the peripheral blood. Or in the there will be a resultant anemia. So the bone marrow will have megaloblasts. The erythroid precursors are large, even the myeloid precursors. There is giant granulocyte precursors also, and large bizarre megakaryocytes. حجمها كل الخلايا بيكون حجمها كبير في البون marrow. فthis is the cell of a megaloblastic anemia. The red blood cells are very large with MCV, with high MCV, and the neutrophils in the peripheral blood will have more than 5 lobes of the nucleus. We call them hypersegmented neutrophils, and this is a characteristic feature of megaloblastic anemias. So folate deficiency, the causes of folate deficiency are either poor diet, like in in poverty areas, and during infancy and in the elderly. Or there is an increased metabolic needs like in pregnancy, chronic hemolysis, like sickle cell anemia. دائما في proliferation عالي للخلايا وبالتالي we need more folate and the patients will develop folate deficiency. Sometimes there are problems in the absorption of folate, like acidic food, for example, certain drugs like phenytoin, celiac disease, because the folic acid is absorbed in the duodenum or the first part of the small bowel. which is affected in celiac disease, like with iron, and also it can be problems with the metabolism of folic acid, like in patients taking methotrexate, a chemotherapeutic agent. So we have also to identify the underlying cause of folate deficiency. The problem with folate that it's present in so many resources, food resources. However, it's highly sensitive to the cooking. So it will be destroyed in the first 5 to 10 minutes of cooking. So the body will not take a high amounts of folate. So the body cannot store folate for a long period of time. Neurological manifestations are absent in folate deficiency. The patients might get sore tongue. In vitamin B12, or the other name for it is copylamine deficiency anemia, the absorption of vitamin B12 is complex because it needs the gastric acidity, it needs the pancreatic enzymes also to elaborate vitamin B12 from its resources, and it needs to bind to the intrinsic factor which is produced from the stomach by the parietal cells of the stomach. It complex with the vitamin B12 in the small bowel, and it passes to the terminal ileum, to the distal ileum, where it is absorbed. So the absorption process is complex. Any deficiency of the intrinsic factor, any disease in the terminal ileum, any disease in the stomach itself will affect the absorption. However, it is stored in the body in adequate amounts for 5 to 20 years, not like folate. The vitamin B12 deficiency leads to demyelination of the posterior and lateral columns of the spinal cord, so patients will have neurological manifestations. If you give patients with vitamin B12 deficiency folate, they will have a correction of their anemia, but they will not have a correction of their neurological manifestations. The causes of vitamin B12 deficiency, it's virtually never caused by inadequate intake because it's present in so many foods, خاصة الanimal resources, except the vegetarians. Vegetarians will develop vitamin B12 deficiency because vitamin B12 is not present in good amounts in the vegetarian diet. Most frequent cause is malabsorption, which is mostly due to pernicious anemia or autoimmune atrophic gastritis, because in this disease there will be destruction of the parietal cells in the stomach, وبالتالي there will be no production of intrinsic factor, وبالتالي there will be no absorption of vitamin B12. Other causes like gastrectomy, because the gastric juices are important in the absorption process, and the parietal cells are important in the synthesis of the intrinsic factor. Ileal resection, because the terminal ileum is the site for absorption. Crohn's disease, because Crohn's disease it's one of the chronic inflammatory bowel diseases. Also, it affects the terminal ileum, so the patients with inflammation of this part will have malabsorption. And elderly patients. The clinical features as in other anemias like the weakness, the fatigability, the pallor. بالإضافة هون بيكون في عندهم beefy red tongues due to the folic acid, and vitamin B12 are also important for the maturation of epithelial cells lining the tongue. Spinal cord disease, هدول البيشنتس بيجوا بsymmetric bilateral numbness, tingling sensation and burning sensation in their feet and hands, sometimes a severe unsteady gait and loss of position sense. If you measure the vitamin B12 levels will be low in the blood. Sometimes folate levels will be normal in order to say that this is vitamin B12 deficiency. The anemia is megaloplastic, that the cells are large, macrocytic, MCV is high. So these patients also might develop leukopenia and hypersegmented granulocytes in the peripheral blood. Leukopenia because vitamin B12 also is needed for the production of the myeloid series. There is a dramatic reticulocyte response to parenteral vitamin B12 uh, if it is given intramuscularly to these patients, they are treated with intramuscular vitamin B12 because it will give a rapid response in the bone marrow and the reticulocyte count will be increased, meaning that the bone marrow رجع يعمل red blood cells. Another type of anemia of decreased production is called aplastic anemia. Aplastic anemia, it means it's a damage or it's a disease of multipotent myeloid stem cells in the bone marrow. It affects the erythroid precursors, the myeloid precursors, and the megakaryocytes. So there will be bone marrow failure and pancytopenia, thrombocytopenia, granulocytopenia, and anemia. The causes are either extrinsic immune-mediated suppression of the marrow progenitors, like patients taking drugs, chemotherapy, radiation, toxins, some viruses like virus B19 infection, other infections, and environmental insults. Activated T helper 1 cells produce cytokines that kill hematopoietic progenitors in the bone marrow, and those patients will respond to the immunosuppressive treatment against T cells, and this will restore hematopoiesis in 60 to 70% of cases. 5 to 10% of patients they have intrinsic abnormality of stem cells and inherited defects in the telomerase enzyme. This will lead to progressive shortening of the telomeres in their chromosomes or in their DNA and the premature senescence يعني الخلية بتصير هرمة بفترة أسرع وبصير فيها death. لكن most of the cases of aplastic anemia are attributed to the first cause which is an extrinsic immune mediated suppression والدليل انه هدول البيشنتس بيتعالجوا بimmunosuppressive therapy وبيستجيبوا. The clinical features of aplastic anemia are pancytopenia. Every single line is affected in the bone marrow. Slowly progressive anemia. The anemia will result in the anemia manifestations. The thrombocytopenia will result in petechiae, ecchymosis, and bleeding. Neutropenia will predispose these patients to serious infections. Examination of the bone marrow is mandatory in cases of aplastic anemia or pancytopenia in order to exclude other causes of pancytopenia. So this is a picture from the bone marrow in which the bone marrow is replaced by fat and there is a decreased hematopoiesis. Anemia of chronic inflammation, it's the most common anemia in hospitalized patients. Suppressed erythropoiesis by systemic inflammation. It occurs in the setting of chronic microbial infections like TB, for example, chronic immune disorders like rheumatoid arthritis, for example, and others, and neoplasms or tumors, cancers. The pathogenesis stems from the high levels of plasma hepcidin produced from the liver, induced by the interleukin 6, which is produced in the chronic inflammation. This hepcidin blocks the transfer of iron to the erythroid precursors in the bone marrow. فالiron بيضل موجود في البون marrow في الماكروفاجز. It is sequestered in the macrophages. وما بيوصل للإريثرويد precursors. ثاني mechanism that the chronic inflammation itself impairs the erythropoietin synthesis by the kidney. Administration of erythropoietin and iron can improve the anemia in these patients, and it is cured by treating the underlying disease. The clinical manifestations are similar somehow to iron deficiency anemia because the main principle is that iron is not delivered to the precursors in the bone marrow. So it will be like iron deficiency, even the cells will be small, microcytic, hypochromic anemia. Serum iron levels will be low also, and there is a decrease in the reticulocyte count. فبالتالي it is similar to iron deficiency anemia. However, it's different from iron deficiency is that the stored iron in the bone marrow is there and the serum ferritin is increased. فالايرون بيكون موجود داخل الماكروفاجز in the bone marrow. The total iron binding capacity is reduced على عكس الايرون deficiency anemia. So هاي الفروقات الثلاثة هي ال different from iron deficiency. So if you perform an iron stain in the bone marrow, it will be increased. This blue color is the iron in the bone marrow. The last anemia of decreased production, we call it myelophthisic anemia, and it is due to extensive infiltration of the bone marrow by tumors or some other lesions like inflammations, granulomas, for example, most commonly associated with metastatic disease. That there is a cancer elsewhere in the body, and there is a metastasis or involvement of the bone marrow by these cancers. So the cancer cells will replace the bone marrow cells, leading to pancytopenia, like metastatic breast cancer, lung cancer, prostate cancers. هدول they have a tendency to go to the bone marrow. Also advanced tuberculosis مرض السل ممكن برضه the bone marrow will be replaced by granulomas. The red blood cells in the peripheral blood بيبينوا misshapen نتيجة البريشر اللي بيصير عليهم في البون marrow because of the replacement. So the red blood cells in the peripheral blood will resemble teardrop cells. And those patients will have pancytopenia. And thank you for listening.